Good afternoon, everyone, and welcome to the last RCPsych Live Members Webinar 2020. Croeso, prynhawn dawr I bawb, rwy'n Ollie John, rheolau Coleg Bryhynol Pysych Rhythryddion. My name is Ollie John. I'm manager at the Royal College of Psychiatrists in Wales. I have the pleasure of introducing and chairing this webinar, Sustainability and Mental Health Care Delivery, How to Learn from the COVID-19 Crisis. It's both a significant and relevant topic, and furthermore, I'm introducing three excellent speakers who I'm delighted to know well. It's the work and commitment of our three speakers today that developed the Cwtch project, which you'll hear more about, and are delivered through the excellent team at Tech Cymru, which you'll also hear more about, the whole service NHS Wales response for video consultation and telehealth. In Wales, we can't forget and must take pride that this work began and has been informed by psychiatry. Lessons that are being learned will be taken forward into the future of services that are absolutely applicable everywhere. So our speakers today, we have Professor Alka Ahuja. Alka is a visiting professor at the University of South Wales, a consultant child and adolescent psychiatrist, and the national clinical lead for Tech Cymru. She'll be presenting on how things have changed, the rapid adaptation of mental health services to the pandemic, and the wins and losses. Gemma Johns. Gemma is a program manager and research lead for Tech Cymru. She'll be presenting on what is the sustainability of our new normal, the ecological impact of remote working on the environment, what patients, families and clinicians think of sustainability, and the impact on workforce. And lastly, Dr. Jacinta Tan. Jacinta is a child and adolescent psychiatrist, a medical ethicist and project manager for the Cwtch project. She'll be presenting on building back better. How can we build a new model of mental health care delivery, which is a more robust and sustainable model? So we're all very used to these things now, but please do pose questions in the functions at the bottom of the screen. We'll look to get through as many as we can during the course of this webinar. Any we miss will be responded to and answers will be available on the college's website. So without further ado, please enjoy this webinar, and I'm delighted to introduce our first speaker, Professor Alka Ahuja.
Thanks, Ollie. Good evening, everybody. It's a pleasure being here. And before I start, a huge thank you to the college, and especially to Catherine, Chloe, and their team who've made this possible. And they've been working very hard behind the scenes to enable this to happen today. I'm trying to share my... Catherine, do you mind sharing it? For some reason, it's... I've got it. So as I said, we'll be talking about how things have changed, and I suppose things have changed for all of us personally, professionally, with family life, and the very fact we are talking the way we are at the moment is a huge change. Next, please. I'll start with going back to Cwtch, which was connecting with telehealth to children in hospital, which started last year, and then move on to how mental health services have adapted. And I think we can be very proud of the way we have changed overnight and taken on the mammoth task of continuing to deliver safe care to our patients and families, sharing good practice, and then what the future holds for us. Next, please. So Cwtch, which was funded by Health Foundation as part of their Innovation for Improvement program last year in January 2019, was looking at offering video appointments to young people in the camp service who were admitted to the pediatric ward following self-harm or a serious eating disorder. Thinking of last year, January, video appointments were quite a novel way of offering care, and we were going to be evaluating that. Next, please. So when we started Cwtch, we started with offering appointments to very risky individuals as part of the emergency assessments by the crisis and liaison team. But the more we did of it, the more we realized that this could be used in the community for follow-up appointments, medication reviews. We opened virtual appointments to GPs, schools, which I'll come back to, and also started delivering groups virtually to our families and carers. We were mindful that this had to be in a safe context, and Attend Anywhere was a platform that was being used in our health board, and we were offered licenses. So we started using it. Again, had consent and all the governance pathways in place. We identified coach champions who were rolling out training and support, and dedicated rooms, because the last thing you want with technology is somebody going in and the laptop not working or the camera not working. So we had coach rooms where people could book in a slot and use it to offer appointments virtually. Next, please. One thing which I would emphasize, and probably is the take home message for me, is whatever you do, evaluate. If you are trying to do something that's going to be innovative, novel, which it was in our case, evaluation was at the heart of it. We captured baseline measures from parents, carers, young people, professionals, and the public, because we wanted to know whether what we were doing remotely was as effective, different, taking more time, or was something that our young people were not keen on having. We had very good feedback, and obviously, the young people were engaging well. We did encounter resistance more on the clinician end, but we're trying to make a breakthrough. We work closely with our mathematical modeling department because we wanted to incorporate remote working into our day-to-day work. So we developed super cool rotas where we had face-to-face sessions along with remote appointments interspersed. And again, we all know in mental health, there's always an imbalance in demand and capacity. And how could we make sure that we were looking after our workforce and not adding more stress by introducing this new way of working? Next, please. This is a slide which management love, because in the 9 months of doing Kuch, we identified that we were saving not only clinician time and time taken to travel, but the biggest nightmare was actually finding a place to park. And the travel expenses, the carbon footprint, and this was something that was being fed back from clinicians and families. Next, please. So along came COVID, and again, whom you can see there is our health minister and chief medical officer in Wales, and Kuch was identified as an exemplar to roll out video consulting across Wales. And we developed a Kuch toolkit, which again, I'll talk about, and started disseminating the information and the learning we had from our Kuch project. Next, please. We had our successes, and again, social media has been very helpful, because I do know that there are pros and cons of using that, but that was a way where we managed to link up with other colleagues who were doing similar work and also disseminate what we were learning. Next, please. So along came COVID in March, and I suppose it was one of those moments where we remember where we were exactly when the lockdown was declared, or where we were exactly when the first case was reported, and our whole world turned upside down. Next, please. This was an article that came very early on in the BMJ, and it was looking at mental health services in particular, and there were some really fantastic examples of how services had adapted, be it the liaison service offering mental health triage in A&E departments, substance misuse services, how they were monitoring and introducing newer drugs so that they could keep their patients safe, or drugs which they were confident about using, the crisis team. And I think we as mental health clinicians are quite resilient, and I suppose in some ways, necessity is the mother of invention. So moving on, next please. So what's occurring in Wales? You may have guessed I'm a Gavin Stacey fan. So in Wales, Welsh government funded the National Video Consulting Service, which rolled out video appointments across Wales so that people could access health and social care in a safe way, and also protecting the workforce. This was in line with Healthier Wales, which is a policy that brings health and social care closer to people at home. And this is being hosted by Tech Cymru. Gemma, who will be doing the presentation after me, and I was seconded to the national team, and the rest is history, because it's just been non-stop since then. Kuch was used as an exemplar, so I think we are proud to say that mental health was doing work that was then identified as good practice, not only within our own health board, but across Wales. Next, please. Again, we started with primary care, and within weeks, we had covered almost 90% of GP practices. But I think one thing that I would like to highlight is, being a mental health professional, I was always interested in knowing what was happening in terms of mental health. And not surprisingly, GPs out of hours identified mental health as something they would like to carry forward post-COVID, even in terms of working virtually. Next, please. Similarly, along came Easter weekend, the minister announced that we roll out remote consultation across secondary care. So this was hospitals, community care, COVID wards, palliative care, hospices, ITU, something that we never dreamt of and never imagined that we would be making those human connections between people in hospital with their family and loved ones, and on rare occasions, even saying their final goodbyes. Again, among all our health boards, we've got health boards compared to trust as in England. All the health boards identified mental health, CAMS, neurodevelopmental services as a priority area. And we've done more than 90,000 consultations as of this week. The quotes at the bottom are some of the feedback we've had from families and professionals. Next, please. We then moved on to care homes, which was again reaching out to the most vulnerable and high risk individuals, working alongside Digital Communities Wales. And I would like to flag up that, we talk about digital poverty and digital exclusion, but this was something that we were very keen on making it happen. And it was not only distributing the equipment, but obviously offering the training and support that was needed so that GPs could do virtual ward rounds and they could link in with the mental health services. Again, couple of projects that have worked well and are being rolled out is Ask Us About Dementia, which I'll talk about, and the Digital Coach project, which was supporting the workforce and their well-being. And this was open to care home managers. Next, please. We then moved quickly into other settings, the prisons, Welsh Ambulance Service, police. There's still work being going on about mental health act assessment, and that may be something that we need to take on in the future, looking at how we can make them safe. And we're now rolling out into dental, optometry, and pharmacy. Schools is something we did work as part of Kuch, because last year, this time, we had a couple of suicides in our area, which meant that following this, referrals from schools tend to go up. And there's a lot of anxiety that needs to be contained, but not necessarily all these young people need specialist services. So we opened virtual clinics, which were drop-in clinics used by schools along with their pupils and family, which received very good feedback. And this is something that we are now working with schools on, because we know post-COVID, schools are not going to be the same. And there's probably going to be greater need for offering support, physical and emotional, to children, young people, and school staff. So this is something that we are quite keen to take forward. Next, please. Again, as I mentioned, we've been running virtual groups for past 5 years, and this has been run mainly for families and carers of young people with autism. These were run by speech and language, dietitian, occupational therapist, educational psychologist. But post-COVID, again, with social distancing, groups are not going to be possible. People are not going to be allowed to meet in community centers. And there's going to be much huger demand for this to be happening virtually. So we've already started developing groups for early intervention psychosis, eating disorders, perinatal, autism spectrum, and many more. Next, please. One thing that we were mindful, and I have mentioned earlier, is evaluation. We had a mixed methodology where we were capturing live data by surveys, both at professional and patient end, but also engaging with the public through open days and engagement events. We've now had more than 300 interviews with professionals and about 26,000 plus survey responses, because I think with evaluation, doing our constant PDSA cycles, we were improvising as we were going along and learning a lot, which we are able to share. Next, please. So just to say, we've done 94,000 consultations and 28,000 responses. Again, 91% of our patients had said that they would use VC again, savings in terms of carbon footprint, reduction in travel, and 50% of professionals reporting a reduction in DNA. One thing, again, I would like to highlight is that more than 20% of people using this are above 65. So it's just being mindful. We're not excluding somebody because of their digital illiteracy. Next, please. This just flags up. Next, please, Chloe. I think it's just going to... Thanks. Next. So again, I would suggest go onto our website. There are loads of resources, but thinking about the new normal in mental health and how we move forward. Next, please. We've developed a Kuch toolkit, which has been endorsed by the Royal College of Psychiatrists. And this is specifically for telepsychiatry, for any team wanting to set up and go through the whole process of starting from ready, steady, go to developing a virtual clinic or service in their own health board or trust. Next, please. Again, the core principles are, setting a team, getting everybody to sing from the same hymn sheet. I'm not one for using collaboration and co-production lightly, but I do think that's at the heart of the Kuch principles. Again, in our population of patients, safeguarding who's suitable, which sort of conditions we've realized already, and these are sort of things we need to build up on. Some of our patients who have high levels of anxiety and were homebound found it much easier engaging remotely. Some of our patients who had never revealed abuse or traumatic episodes have started sharing that, but these are anecdotes, and again, this is something that needs to be taken further. We did find that some of our young people with autism were very tech savvy and actually engaged better, whereas some of our other young people with autism found it much harder. Being mindful of risk, safety, how do we maintain confidentiality when you're doing these assessments? How can you make sure nobody else is hovering around in the background or putting their ear against the door and listening to what's happening? Measuring satisfaction, evaluation, and then how do you make that sustainable? Next, please. So just sharing what we learned in terms of COVID and mental health, we found that things changed overnight. The teams were very adaptive, resilient. They started using remote appointments in outpatient settings, community teams, inpatient, crisis teams, substance misuse, MDT, multi-agency meeting. In particular, as regards mental health, we've had 1,028 survey responses, of which almost 80% have rated it as excellent, very good, and good. And it has prevented face-to-face in 87% of the consultations. Now, preventing face-to-face obviously means that people didn't have to come to clinic, which was obviously protecting them from infection, but also thinking about our patients who are very anxious, and especially for some of our young people where seeing somebody in PPE can be quite a frightening experience. There's a significant difference between patients and clinicians on their quality rating. Although both of them rated it high, patients actually rated video consulting more positively in our experience. Next, please. Again, with care homes, what video consultation enabled was not only delivery of care, but also linking some of these most isolated individuals with their families, opportunities which they would not even have under normal circumstances to attend birthdays, anniversaries, parties, and occasionally funerals. And this had a huge impact on their well-being, because it's not just about mental illness, about mental well-being that's equally important as mental health professionals. We've done 101 interviews so far with care home staff, and we're now getting better understanding of the use, value, and benefits and challenges of using video consulting in mental health care. They are getting more and more responsive, and acceptability is increasing. There's still work to do around training, supporting them, but something they want to use is in primary care and mental health, which is going to save getting the most vulnerable people to a hospital appointment, which often means getting key worker along with them, arranging an ambulance, public transport, spending a couple of hours going back and forth. And occasionally this can be quite time consuming and have huge impact on the workforce in a care home. Issues around connectivity, lack of equipment, and technical literacy have been flagged up, but were not perceived as barriers by care homes. Next, please. Similarly, as I mentioned about schools, the whole school approach in Wales is about bringing health and social care into schools and to the communities. I'm currently working with education and policy leads developing governance pathways and protocols, because we want to develop guidance. We want to make sure we are able to deliver care to young people in a safe setting, being mindful of safeguarding, consent, confidentiality. We look at it as the TLC model, where we're offering training to staff and to carers, offering consultation and then clinical direct care, which is needed one-to-one. So we've got Q&A sessions. We've started with a group of professionals, which started with speech and language, occupational therapy. We've got one on mental health, which is open to all schools. And the last session was actually yesterday. And we had about 100 plus schools that have engaged. And this is teaching assistants, dinner ladies, people who would never otherwise get a chance to learn or talk about children that they are concerned about. Parent groups, we're doing intergenerational work and working with Duke of Edinburgh Award young people, and Gemma will talk more about, and engaging them with the work that we are doing, but also with care homes, because very often young people pre-COVID would get the opportunity to go and visit care homes and teach the care home resident digital literacy or digital skills, and in return get a lesson in history or learn about the World War. But that's not going to happen. But why can't we make it happen virtually? Developing community hubs, which again is a model that we are quite keen to pursue, where schools could identify a room, and this may not be every school, but a room where there is technology set up, which could be open for delivering appointments for young people in the school, but even the wider community, a bit like how the libraries work. We've got a school survey we've sent beginning of this month, and this is to ask schools about how they feel in terms of using remote access to care and training. Next, please. And again, there's huge interest, and specifically in terms of training and supporting parents and staff. Next, please. As I mentioned, Ask Us About Dementia is a pilot project we're working with, where we've got a group of professionals working along with third sector and carers, and they offer Q&A sessions and support sessions where people can drop in, book a slot beforehand, and get advice and support about queries they have. So this has been patients, carers, care home managers. And again, it's been really helpful because it's allowed sharing of learning across disciplines and across boundaries, because that's one thing. People don't have to travel. So, it's just enabled people with expertise to be tapped into from other parts of the country. Next, please. So it's how do we share good practice? How do we not get precious about what we are learning? Because we've seen that, we've shown remote working to be working in the community, working with people in their homes, delivering care, but making sure that something like this is sustainable. And that's the challenge that's going to be moving forward in the new normal. We are aware that there are lots of mixed messages, and as a country, we have experienced that over the last few months, but we want to give a common message and get everybody on board. Next, please. So as I mentioned, there's work being done with UCL looking at delivering psychological therapies to people with depression and dementia, neurodevelopmental assessments, memory clinics, medication follow-ups, virtual ward rounds, and the list is endless. Next, please. So do we want to do more of the same or more with the same? It's just looking at how we can exploit digital technology to support us to make better care available for our patients. Online self-assessment tools, which can be identified to triage patients, online resources, apps, websites, that have evidence, or things like Silver Cloud, where they can deal with mild symptoms of anxiety and depression. And we need to now evaluate and see what is the evidence for it and where it works, where it doesn't work. COVID has almost opened the door to technology. And we know that following the World War, we had the birth of NHS, and it almost seems following COVID, we'll have a newer NHS. It's looking at modeling, supporting forecasting, working with demand and capacity imbalance and shaping as we go along. Next, please. So the future direction is, again, it's almost going around in the same circle where, the genie's out of the bottle, we can't push it back again, but looking at which cases we as clinicians feel that remote consultation has a role, being mindful of equality impact assessment, you're not leaving out the learning disabled, the old age, the people from, ethnic minority. How does it compare to face-to-face? We're already hearing about Zoom fatigue. We're already hearing about people feeling the need to link up, network with others. But then on the other hand, how do we access second opinion? How do we allow input from families and carers who may be abroad? Recent studies have shown that virtual consultations can be as empathetic as face-to-face, but it may be that's a specific training need that's been identified, and it's working with our undergraduate and postgraduate trainees and HEE, HEIW like organizations to build it into our future training. Preferences, choices, some people have found delivering sensitive messages remotely much easier, because it means people can then have them in the comfort of their home and don't have to sit in a clinic and then drive home with the bad news that they had. Others have found it much easier face-to-face. So I think this is something that we will learn as we go along. Training, again, we would have never had a webinar where we've got, Catherine last told us, 784 people registered. It's just opened our horizon. We've had opportunities to link in with international expertise, which would have never been possible in normal circumstances for various reasons. Strong relationships are required clinically and between digital leaders, and the evidence and toolkits to take it forward. Next, please. This is a short video that I'll leave you with about some of the work we've done in care homes. And it's something that's very touching and just conveys the message.
Oh, hello, with Nana's big boy. With Nana's big boy. Oh, hello. Kiss a kiss, with Nana's boy.
Yeah. You do as I do.
Mary o Ddiwrth 9. Da ni'n iawn?
So thank you. This is a lovely team I work with, and it's as each one of us having responsibility of picking up the best things from this horrible experience we've had over the last few months and moving ahead. There's always a silver lining to every cloud, I believe. Thanks a lot.
Thanks so much, Alka. Every time I see that video, I don't know how many times I've seen it now, but it's so powerful. I'm delighted now to hand over to Gemma Johns, who's the Programme Manager for Tech Cymru and also a research lead.
Hi, everybody. Who's sharing the slides? Okay, so I'm going to talk today about what is the sustainability of this new normal. So I'm going to look at the ecological impacts of remote healthcare on the environment, what patients and families and clinicians think here in Wales, and the impact it has on the workforce. Next, please. So there are rarely subject matters that remain untouched by the COVID-19 pandemic, but one area in which COVID has caused positive and negative impacts, both indirectly and directly, is that of our environment. So the spread of the virus drew the economic activities of many countries to a halt, causing the cancellation of flights and travel across national and international borders. Many countries around the world went into social isolation, and many of these countries had to go into quarantine measures. So not only is this going to cause vast impacts on the psychological and physical well-being of our populations, but it's likely to have huge impacts on our environment. But much of these environmental impacts remain largely positive. However, the negative impacts are reported to have much greater and long-lasting impacts. Next, please. So one environmental impact is that the reduction in air pollution and greenhouse gases. So the quarantine measures that were enforced across the world, many parts of the countries, made people force people into their homes, and major air pollutant sources such as human mobility and industry stopped. So this reduced the associated emissions from typical traveling by flights, road and rail. So it was estimated quite recently that there was a 30% reduction in nitrogen dioxide emissions around that time, and up to 80% reduction in hazardous particles in the air and water. So, but not all these impacts are necessarily long-term, so these are not too bad. Next, please. However, one of the biggest and most worrying environmental impacts at the moment is the long-term impact it has on plastic production and waste that we're seeing right now. Much of this is associated to the PPE and the need for safe functioning of our healthcare services. It's been estimated that since March, 129 million face masks and 65 billion pairs of plastic gloves have been used on a monthly basis, which includes masks, gloves, plastic aprons and visor shields, all of which are non-recyclable plastic and presenting a massive challenge. So this impact has reversed recent single-use plastic laws across many countries, including here in the UK. So the use and mismanagement of these plastics are causing both local pollution, but they're so small and light, there's concerns that they can go into streams and currents and cause worldwide pollution. Next, please. Another positive environmental impact due to the restriction of human activity has allowed many wildlife to reclaim previously human-dominated spaces. For example, there's been some lovely reports in the USA of wild coyotes. There's been rarely seen insects around England, and there's been wild goat and peacock being spotted in North Wales. There's been reports of temporary reductions in traffic collisions involving wild animals. There's been improved water quality and the return of fish and marine life into urban waterways. We've seen a 50% decrease in sewage and industrial waste in rivers, and a 15% reduction in hazardous particles in lakes. We've also seen a lot of other impacts, such as efficient household food management is starting to show improvements, such as food waste is reduced, and a lot of consumers now are switching to frozen and cupboard food compared to fresh food. Next, please. So as in technology-enabled care, we're here to enable the sustainable use, scale up and spread of digital services. And as a response to the COVID-19 pandemic, Tech Cymru developed a new NHS Wales video consulting service, which Alka just presented on. We identified environmental impacts as a significant benefit to remote healthcare, a benefit which was reported by professionals, patients and families, which appears across our large data set to be influencing VC uptake significantly. And it's this benefit itself which is key to remote healthcare for the patient themselves, but also for the professionals and the associations to wanting to work remotely. So we've been analysing our data sets, and one of, like I said, one of the biggest and important updating is that of the benefit. And we're starting to realise that this benefit may be the secret to sustainability of video consulting. Next slide, please. So here's an overview of our some of our stats, which have environmental impacts associations across the 9 months that we've been rolling it out. So as Alka mentioned, we've had 28,000 research participants take part in our research. 93% of our patient groups have been rating the use of video consulting across a wide range of specialities as excellent, very good and good. We have an incredible but very consistent demographic in that across ages and across the suitability and across satisfactory has remained consistent for almost 10 months now, which I think across a data set the size that we've got is impressive results. Some of the findings that have come out, as Alka did touch on earlier, we've got a 75% prevention of face-to-face, which has been reported from both patients and professionals. And in Wales now, 30% of our professionals are reporting to be working from home. So huge savings there on, 75% across almost 100,000 consultations of savings on things like PPE is a massive, massive savings to the environment. 30% of professionals working from home, not having to travel and adding into all that. So huge savings just from those two statistics, really. But also it's been quite interesting is we've been calculating travel savings that the patients have been able to report. So across 100,000 consultations, we've collected 27,500 surveys. And I would say about a quarter of them have reported their travel. So this is a segment of what's been saved, but as you can see, it's still a huge savings. And the savings that we've managed to calculate is an estimate of 33 trips from London to Auckland. So if that was calculated by every single person using VC, I'd imagine they've huge savings. So next slide, please. So here's a couple of quotes. We have got hundreds of thousands of quotes. And I would say quite a few thousand relating to environmental impacts and savings, but here's a couple from a few of our professionals. And like Alka said, patient satisfaction is so high, but so is clinicians. And I think they are rating lower. It's about 93% are rating high of patients and about 83% of clinicians. And clinicians, you know, are the ones holding all the risks. So obviously their rating is going to be slightly lower. But the quotes that they provide and the ones that are associated to savings and the environment and the other types of benefits are just incredible to read. And we've got so many of them. I could do an entire presentation just on quotes. So it's just been fantastic. So next slide, please. So like I just outlined, Tech Cymru are positively contributing to the environmental impacts of the virus by way of offering remote healthcare. So we've saved travel and CO2 to patients who are reporting it. Across 90% have said that they've saved on travel and time off work and school, which would contribute to additional travel at 65% of the time. The prevention of the need face-to-face at almost 100,000 video consultations across 95% of the time, huge contributions towards plastic waste and PPE. And again, enabling professionals to work from home. So it's contributed to less travel, emissions pollution, possibly food waste, paper waste, and maybe a little bit towards helping towards the protection of wildlife and not being out on the road as well. So Tech Cymru's research so far suggests that benefits themselves determine video consulting use and value, and that the uptake is higher when benefits are perceived as high too. So therefore, based on what we have found so far, we'd suggest to sustain video consulting, then perhaps focus on the benefits it can offer and improve on them whilst moving forward. Next slide, please. So here's a little clip which outlines our new normal, which is not necessarily that normal right now, is the foolish humans. You know, just when the air begins to get clean, they start wearing face masks. So we are in a crazy time. So next, please. So central to Tech Cymru aims and Welsh Government policies, we're producing a world that's suited to our future generations. So to understand more about what this means, Tech Cymru were keen to learn more from our future generations, and that is our young people of Wales. So Tech Cymru researchers approached some young people around Wales who had already been previously involved in our evaluation to contribute to some further research. So we had some initial conversations with them, and they expressed an interest of developing a video with us so they could share their message and help inform policy on environmental impacts. So we took this on board and we asked them this one question. How has COVID-19 pandemic impacted on the environment? Next slide, please. So due to lockdown restrictions, we couldn't go visit these young people and record them ourselves. So we asked them to self-record video clips for us and send them over to us. So in total, we had 22 video clips, which included, I've said 24, but I think it's actually 26 because there was 2 kids and quite a few videos. So 26 young people, and they ranged between the ages of 2 and 23 years of age. And it was from young people across 5 of the 7 health boards, so it was quite varied. But interestingly, regardless of their age, they all provided very common themes of what they believe to be good, bad, and combined environmental impacts. And interestingly, as I just outlined in the background literature, their responses were actually comparable, in my opinion, better, but I have to say comparable to scientific evidence. So it was quite amazing to hear. So these are the 5 themes they came up with: travel, emission and air pollution, water pollution and beaches, protection of the animals and wildlife, recycling and plastic waste, and food and energy waste. So we've just submitted a paper on this, which has been amazing, and it's entitled Welsh Kids Know Best, COVID-19 and the Impacts of the Environment. So hopefully it'll be published soon and you can read that. So next, please. So I'm going to end now with the video that our young people developed. So hope you enjoy.
To drop rabbits.
No people was there where?
At the beach to drop rabbits.
Less people were going around, which kept natural habitats intact so they weren't being destroyed and wildlife was living freely.
Obviously, like, it's getting loads of people, but it's not as much people going out. So it reduces the gases in the air, like from cars.
Why do you think it's better?
Because she's nice.
The sea's nice now, is it?
And turtles can go on the beaches now because there's not much people around to distract them.
How?
Because there's less plastic in the sea because no one's allowed out. Lockdown.
Lockdown.
They're at home, not wasting as much food, and also in light of the recent Free School Meals campaign, people are a lot more conscious about the food they're wasting and the effect it has on the environment.
And less people are going on holiday, so not so many flights and not so many tourists, so less rubbish and pollution from their cars.
Plus there's been a lot less water pollution because not many people have been going on boats to get overseas.
Where do you wear masks to?
In shops.
In shops, well done.
It's whether people are throwing them away in the right way. I've seen lots on the floor outside shops, which are obviously creating a lot of litter in the area.
It's a virus.
Because of the coronavirus, but do you think it's made any difference to our environment?
Yeah. No.
Yeah? No.
And what do you think people should do?
They should stay in.
They should stay in and paint like you, is it?
I think we all really need to focus on making sure we're disposing of this plastic waste correctly. Otherwise, it's going to end up in our ecosystems, especially our marine ecosystems, where it can be severely damaging to the environment.
Since lockdowns happened, people have to stop using their cars, which stops carbon emission. And it's not just cars, it's buses, planes, trains, taxis, all sorts of stuff. So yeah, good job protecting the ozone layer. Good job, people.
In the UK, at least in my lifetime, we have been privileged and lucky enough to not have experienced anything with the same or even similar level of widespread disruption. As a result, I feel like people are being more conscious about the decisions that they're making and their long-term impact on the environment.
Therefore, I believe if we try to improve on these negative impacts and try to keep up the work with our positive ones, we're able to make a better environment.
You know the question I want to ask you, just a second. What do you think COVID-19 coronavirus, has done for the environment?
And that's all from me, so thanks very much.
Great, thanks Gemma. Just before I hand over to our last presenter, Dr. Jacinta Tan, I know there's a lot of questions coming in, which is fantastic. So we'll try and get through as many as we can after Jacinta's presentation, but those which we don't get through, we'll make sure are uploaded to the websites as soon as possible. So I'd just like to introduce now Dr. Jacinta Tan, who's going to give a presentation on how we can build a new model of mental health care delivery, which is more robust and sustainable. Jacinta.
Hello. Okay, I think that it's all right. Okay, what my talk is about today is Build Back Better, and I'm aware there's a movement and I don't particularly have any views. Sorry, I'm going to start my video. I don't have any particular allegiance to them. It's just using the word to think about how we can move forward post-COVID or even in the middle of COVID. Right, here we go. So Build Back Better is a movement. There's actually several different people who use that, but I just wanted to introduce you to the idea that there's this organization that thinks about it, and actually it talks about sources of hope, and you would have seen that in quite a lot of the things Gemma and Alka have talked about. And so what I want to go on to do is think about what we have learned in mental health. Well, when we started Coach, and when I actually ran a review in Wales of eating disorders, people said that telehealth could not be done. It just would not work in mental health. Well, with COVID, things have been done, and they've been done very quickly. So what we have now is the technology to actually work remotely, but we have lots of other barriers that still exist. What we find in implementing telepsychiatry is that clinicians still lag behind the public in embracing virtual consultations, but we know that it's much more sustainable to the environment to offer some remote consultation. What we do find, and Gemma's research demonstrates, is the use of remote consultation can make mental health care a great deal more accessible to patients and families. And this is particularly in the case where there's greater distances to travel or long travel times. And I'm aware in some of the big cities, it may be a short physical distance, but actually it could be really quite a long commute. And there are also benefits, but also risks and new considerations. And it really, going forward, has to be the right modality of treatment for the right patients. So what can we do better? I think COVID gives us the opportunity to step back and take a really good look at the system. Certainly in the UK, mental health works very much in silos. We all work in our little silos, and doctors in particular mainly work at bases. So in psychiatry, we do have support workers and other people who go out to people, but normally we expect people to come to see us, the psychiatrists, on our turf. And that is really something that's grown traditionally, but I think it's a good opportunity to question that. I think what we can think about is our current inequities and the current issues that we have within our mental health systems. And COVID's actually given us a great big shake-up, and we actually could use that opportunity to step back and have a look. So at the moment, expertise is often more available to the very ill. And in my diagram, I'm sort of showing that, for instance, it's the really, really ill who get the gold standard treatment. And then there might be some out there getting mental health treatment, but there's actually much larger numbers of people who are in distress, but aren't seen by mental health services because we have very strict entry criteria. And actually there's movement away from that. So I'm showing you the windscreen wiper model, which is being employed in Wales around seeing different levels of need and then working on appropriate responses to different levels of need rather than having an all or nothing kind of model. So I think when you step back and you look at change, the context is key. So for instance, in Wales, we have several different drivers that have had already come from the government that would be really helpful in thinking about how we develop projects like what Alka has done, connecting with schools, connecting with care homes, and so on. And the documents we already had prior to COVID was A Healthier Wales, which did talk about community-based, person-centered care around the person, not them coming to see us in our specialist silos. We even have the Wellbeing of Future Generations Act, which actually puts a duty on all institutions to consider sustainability, environmental impact, and impact on future generations of everything we do. More recently, we've got the ALN Act, which is the Additional Learning Needs Act, which again puts a duty on both education and health to work together to meet all additional learning needs that children and young people might have up to the age of 25. So of course, necessity is a driver of change. The COVID pandemic has been an absolute exemplar for that. But actually what we need to do is actually learn from what has happened, what has worked, what hasn't worked, to actually set up for change which is more permanent, that outlives COVID. What we don't want to do is for everything to go back to the way it was before COVID, because it actually wasn't necessarily very equitable. It wasn't working very well for patients and for families and for the population. So what Tech Cymru have found in their work of very rapidly implementing change is they actually had to go first to the infrastructure of the organization to talk to those people about what needs to change in order to implement something which everybody agreed was needed, which was the remote working. They then needed to work on clinician acceptance. And it was when the clinicians accepted it and started using it, having had the backing of the infrastructure, that you then get patient satisfaction. So it's not that patient satisfaction is not important, but if you haven't got the rest, you won't get patient satisfaction. There was a question in the chat about well-being of staff. I absolutely think it's key that the way we were working beforehand wasn't necessarily looking after the well-being of staff. And we have discovered with COVID that actually a lot of us are falling like 9 pins because actually we haven't got a traditional structure that looked after our needs. And I think this is the thing that we also need to learn going forward. It is about the system looking after the well-being of its own staff so that we can look after the well-being of the people we serve. So it is about empowerment, control, giving staff options and, choices and so on, and providing them groups, space to decompress and all those kinds of things. What we've learned in the COVID pandemic is that we need to be flexible. We need to be adaptable. We need to be able to support appropriately vulnerability in both our patients and families, but staff are also vulnerable. So there are a lot of staff who actually were shielded. There are a lot of staff who have disabilities. And I think looking after workforce issues is actually also really, really key to develop sustainable models of care going forward. And I use sustainable both ways, both sustainable ecologically, but also sustainable in terms of a system that will continue to work for another 50 years. So the TEC Cymru experience showed us a few things that I think may have wider application, but this is what they found in doing what they were doing. So they had to take a system approach, but they also had to work individually with our Welsh Health Boards, which is the same as the NHS Trust, to tailor the new video conferencing service to suit the culture that was happening in the trust, the health board. So it was the same thing that needed doing, but they needed to work individually with every organization. They did PDSA cycles, plan, do survey and act, study and act. They had to do continual PDSA cycles, and they had to work with who matters most in terms of implementing a change. For an example, they found they were working with appointment clerks to send out the right kinds of appointments so that people knew how to use the video conferencing. Flexibility, ability to adapt to local needs, and also actually letting clinicians see what the need was to buy into change and drive implementation. So the way they worked is they worked with the people who wanted the video conferencing first, and then as this was adopted, other people would be convinced about the need by watching the early adopters and then begin to buy in, and it snowballs. There are different uses for video conferencing in mental health, and we need to also think what is appropriate for our group that we're serving. So you could use VC for triage, you could use it for follow-ups, could use it for new assessments, but maybe it's more appropriate for, say, patients I already know who know me, rather than new assessments where you're meeting people for the first time. So that, obviously in COVID, we have major constraints in terms of what we can do face-to-face, but moving forward, what we should do is consider which are the wins, where we do need face-to-face and where we might be able to use remote to great advantage. What TEC found was not recommending targets was actually quite useful, allowing people to ascertain what the targets were and not having very specific arbitrary things that they force people to self-achieve. And really the model we took in from Kuch was to evaluate. And the whole key was making video conferencing work in terms of fitting in with what needs doing in the clinical work, not the other way. So it is about knowing what is the core of what we do. So a vision for the future, COVID was a reactive change. It was born from necessity. But actually, with the vaccine, hopefully in a few months, things will begin to ease. And then what we should do is aim to move forward with the things we have learned to do proactive change. And I think what we need to do is use the recent learning that actually, do you know what? Things that people said couldn't be done, things that said it'll take 10 years to do, we managed to do in 6 months. So this new openness to ways of working, this new flexibility is an opportunity to do things better. The TEC model of evaluating everything, demonstrating cost and clinical effectiveness is really key to convincing people like commissioners and funders to actually be able to support things. My view is mental health has not traditionally evaluated everything, unlike some other medical disciplines, on satisfaction and outcome and value for money. And it might be because of the way things evolved, and it evolved organically. But I think here's our opportunity to be much more evidence-based, to build robust models, build in the PDSA cycles and evaluate for satisfaction and effectiveness, and then, you know, adapt things if they aren't quite hitting the mark. So I'm really pretty much done. I did it very fast because I do want to leave a few minutes for questions. And the message we want to give to you is those 3 words: evaluate, evidence, and embed change. And it, you know, this cartoon is, it is about how we need to bring together all our understandings, but ultimately come up with what the patients need. Thank you.
Great, thank you so much, Jacinta, and thank you, Gemma and Alka, for between the 3 of you, your excellent presentations. We've had a number of questions in, and as I said earlier, that those which we don't manage to address, we'll make sure are published on the website. But I just wanted to pull out a few, because I think there's some really valid points. And the first one is actually perhaps not a question, but a comment which has got a lot of support, so I'd be keen to highlight it really. Someone who's left a comment who works in assertive outreach and can see some of the most vulnerable patients with SMI who are almost all digitally excluded. They also have very limited awareness of their illnesses, need for treatment, and risks associated with relapse. They don't reliably attend appointments, and many lack digital skills or have distressing psychopathology related to technology. The sustainable solutions must acknowledge this and include outreach for some groups. So I wondered if there's any of the 3 who would perhaps like to just give a comment to that kind of thought. Jacinta, over to you.
Well, I actually work entirely remotely at present because of my own clinical vulnerabilities. And so I'm very pro. But actually, for instance, I had a really vulnerable patient, the kind exactly as you would describe, who had difficulties engaging. But actually what we did was his support worker from the social work side went out to him and sat with him in his bedroom, or, you know, socially distanced, mask on and everything, while I did the video conferencing to him. So normally in camps, I work in camps, we would not, the consultant psychiatrist would not go out to see this young man. And to be honest, I don't think he could have endured much of a session with me, because he would find it quite overwhelming to be trying to see me in his bedroom and so on. So there are creative ways of supporting people to be able to engage with the services. So what I did essentially was a hybrid, and it worked. And it worked far better than when he normally came to see me in the clinics.
Excellent, thank you, Jacinta. Another question which has been posed, how has society's view of mental health influenced the support and resources provided during this pandemic, but also generally? I don't know if anyone's got any thoughts on that particular point.
I'll take that, Ollie. I think one thing
Thanks,
we
Alka.
realized is that we're thinking more and more about mental well-being, which in the past we didn't really acknowledge or accept. And personally and professionally, you know, we've seen that what the lockdown has had in terms of isolation, you know, the novelty of working remotely has started wearing off. We want to be with people. We are social human beings. And I think all of us are trying to make those connections. But the work that we are trying to do with care homes and schools has even further highlighted that it's equally important to flag up the importance of getting in early and the mental well-being, because we've had patients on the hospital ward who were rapidly deteriorating. And I still remember Gemma was trying to interview one of the nurses. This was sometime August, September, and this gentleman hadn't eaten for 3 days. And they were trying to give him IV fluids, which he was refusing. And then one of the nurses managed to use her phone to connect him with his daughter. And just following that couple of minutes conversation and seeing his daughter, he perked up. And by the end of the week, he was sitting up in bed, getting dressed and trying to eat. So I think, we all have had the opportunity to think about all the things that matter to us and really appreciate the small things in life, which we had taken for granted.
Thanks, Alka. Okay, another question, perhaps slightly related, but certainly something which has come up in the chat and presentations. How can we close the gap in health inequality and inequity, especially in this period of COVID? And also, how long can we sustain the new normal and new ways of working, especially in mental health? It's a big question.
Well, I think one of the things about current society is almost everybody has a phone. So if you have a phone, you can actually connect digitally. I think it's slightly different if you are talking about remote schooling or something. But if you're talking about using Attend Anywhere, one of those remote video conferences, all you need is a smartphone. And so people we've been quite surprised. We've worried about digital poverty, but we've been quite surprised how many people have been able to connect. So I would suggest that remote work, video conferencing is more equitable, gives people more access than actually suggesting they have to take 3 buses to come and see me, take a day off work, and so on and so forth. And, spend money they don't necessarily have to come and see me on my terms at the time that I can make it. So it could potentially increase access, but it is all about how we do it. So, and it does mean that it might be easier for people who find it too hard to come to us as well, to actually see us in the comfort of their home where they're, surrounded by familiar things and don't find it so stressful.
Thanks, Jacinta. I think related to that, and perhaps you've touched upon this a little bit in your presentation, there's a question on what ethical considerations were there when the NHS had to think about moving mental health services?
Well, I'm a medical ethicist. There were relatively few ethical issues. I think most of the issues were governance issues, and I will leave Alka to talk about them. I think that's quite different. I think the main ethical issues I would be concerned about would be risk. We need to think very carefully about risk. So for instance, when you see someone on a video conference, you don't know who's behind the screen. So for instance, if someone is being abused, in the privacy of your consultation room, that's a space where potentially they can talk to you about it. But if you are video conferencing them and they're in their home, you don't know who else is lurking around. Although you can ask, and people often tell you so-and-so's here in the room with me, and you can kind of work with that. I think that was the main issue, risk governance that we came up with. But I think a lot of the risks around doing VC was actually more governance issues of how you can actually overcome the challenge of getting the tech in the NHS, getting to work and so on, even having Wi-Fi in your place of work and so on. Alka, do you have something to say about that? Because I work around that.
Going to add that, obviously, it's being mindful of issues around confidentiality, consent, and if there are concerns about capacity to consent, because I know some of the questions are about the most vulnerable. I just think it's trying to use technology to our advantage. So if there are people where this is going to work and we know that we can do it for follow-ups and medication, it just means it frees us time and probably gives us more time to see the ones who need to be seen face to face. So it's trying to, I don't want to use exploit, but it's almost exploiting, abusing technology so that it works in our benefit and the benefit of our patients. We had a lot of apprehension even among clinicians about, do we need to record each and every video consulting? We don't record every face-to-face consultation that we do. What is important is documenting, whatever you do virtually, face-to-face, make sure it's documented appropriately. And, if the patient wants to record, obviously for their own personal use, that's fine. But, if there are going to be recordings, then think about the impact it would have on storing this data and how do you transfer that. So, it's just because it's available doesn't mean it needs to be done. So there are ethical challenges, but that may be something else that we need to think about moving forward, how we deal with it. And there may be patients where it is not appropriate.
Thanks, Alka. There's a question which has just come in, which perhaps touches upon that thought as well. So there are clear cost benefits in the context of remote working, both time and finances. Has sufficient thought been put into making sure that there is not a push to apply this everywhere to reduce cost?
I think maybe Gemma.
So I think perhaps that touches upon what you just mentioned. I don't know if there's anything else you'd like to add, perhaps, Gemma.
No, the one thing we did in Wales here is we did try it everywhere, because I think it was a lovely, we were in an opportunity to try it everywhere. But here in Wales, we're not, we have no sort of set targets of where it should and shouldn't continue. And the Welsh government have been very supportive of that. They're not pushing people to do, after COVID, 50% should be. It's there's a lot of clinical leads behind this with us, and it's being clinically supported, and the decision to use it is a clinical decision, and we as a program support that. So, we understand where it works, where it doesn't work, and it's been, we've only been able to sort of do interviews and surveys at this point, but as restrictions lift and we're able to get into services, we're going to do an awful lot of efficacy and effectiveness work and really testing the clinical effectiveness of VC. And I think once we're able to do that, we'll have a much better understanding. There is no push here in Wales. And I think the one thing that's worked here in Wales is how we did it and how we set it up and how we work closely with the local health boards. So, yeah.
I think the other thing I want to add is it's not for every patient, it's not for every situation, and it's actually not for every clinician, because what we find is different clinicians have very different attitudes to using video conferencing. So if either side's not happy about it, not comfortable about it, and maybe, in some situations where you think, whoa, the risk is a little bit too high, then it's not appropriate. So I do think that what hasn't happened in Wales is we haven't been told everything goes to 100%. I don't think that's appropriate, but it is an additional tool. So when I say build back better, my idea is that we don't just all suddenly revert to face-to-face, having completely forgotten everything we learned. But I'm also not saying we should all continue completely remotely, because that's not appropriate either to a lot of our patients, and it's not what they need. And different patients have different levels of acceptance, just as much as clinicians. And I think what we always need is to offer people choice. That actually, you might want to see with this patient, they're very uncomfortable with it. I can't seem to engage them very well. Well, maybe it's better face-to-face. But it's also been true that the other way around sometimes works better for some people.
Thanks, Jacinta. And just on that point as well, there's a comment which has come in, which I think feeds onto it nicely. So just wondering if digital literacy could be part of an assessment in a bid to adapt to the new normal. But I'm just going to jump ahead to perhaps our final question. Forgive me, there are a number of others, but as I said, we will come back to them on the website. So COVID has brought a greater understanding of the interconnection between physical and mental health, and also the interconnection between healthy people and a healthy economy. Do you think this understanding will last beyond the pandemic? It's a good question.
It is a very good question. I hope it will, which is why we proposed this webinar, because, we had to do what we had to do. My hope, and that was what my entire talk was about, is what can we learn to make a difference going into the future? So if COVID magically went away tomorrow, what can we learn that actually makes our service better? Or do we just go straight back to what we did before, which we don't think was perfect? So I think on the whole, we've now all got the digital infrastructure, which we didn't have. And that hopefully will at the very least be available from now on. And that might be an opportunity, but I think we as clinicians need to be very strong in saying, and yes, I want to continue using it in this kind of situation, but not that kind of situation, and be part of that dialogue about how we take it forward.
And I think, I'll use the example of schools, because when we started with schools, we were thinking very narrow vision in terms of mental health. And the more, Gemma and her team did the evaluation, we found out speech and language therapists, physiotherapists, occupational therapists, dietitian, dentist. Children have every 6-month dental checkup, sexual health. They were very keen to see these young people who were not being seen because of lockdowns, because of professionals not being allowed in schools. And the opportunity to work virtually is going to offer so many more avenues of offering care and support to some of these young people, because we know in camps, for example, a lot of our young people are either excluded or on reduced timetable. So then to get them out of school to come and attend an appointment, which is going to be a couple of hours, is that going to be good use of their time and the disruption? Because some of our ASD kids, they like structure, they like the routine, they don't want to be coming to hospital to see us, and not taking it personally, but why can't we get closer to delivering that care where they need it in the school setting, which also empowers the school staff and makes it a more joined up approach?
Great, thanks, Alka. And I'm just seeing some of the comments in the group chat as well. So that's something for I think all of us to reflect on. Lots of comments around challenges, but lots of comments about keeping hold of this innovation and how we move forward as well. And we take the lessons that we've learned throughout this time. I think time has beaten us, unfortunately, and it's probably time to close the webinar. But I would just like to say thank you for attending, for engaging with such great questions, such great comments, and thank our 3 presenters and the whole events team at the college for the presentations, facilitating all of this work. And I think lastly, just to wish everyone a safe Christmas, and yeah, hopefully see you early 2021 for a different RCPsych webinar on a different topic.
Look after your
have a good evening, everyone.
over Christmas. Thank you, Ollie.
No worries. Thanks, everyone.
Bye.